Hello, everybody. This is Matt Wald. I'm from the Running SIG, and I'm going to introduce us to our topic today. We have clinical application of imaging results with injured runners. We have four great guests. I'll start with myself, actually. I work at the University of South Dakota. I'm an associate professor. I conduct research with runners. Primarily, I am a runner. My patient population is primarily the collegiate athletes here at USD.
And I'm Christa Wille. I'm from the University of Wisconsin-Madison, where I am currently teaching, but also see patients in the area here as well. I also primarily work with endurance athletes and especially enjoy working with runners.
And my name is Eric Greenberg. I am an associate professor in the Department of Physical Therapy at the New York Institute of Technology. I've been a member of the Running SIG for a long time now. I do a lot of consulting on various running injuries with a focus a little bit more on the youth athlete, and do primarily teaching and research in my current role.
And I'm Jacques Soroy. I'm a third-year PT student at the University of Wisconsin-Madison, wrapping up and graduating in just a couple weeks, and will be starting residency at the University of Florida down in Gainesville starting in August. I also have an extensive running background, so super excited to be here.
Fantastic. All right, let's take a look at the objectives for our talk today. All right. First objective here is to review common imaging findings that should impact patient care. Second one is to scrutinize common imaging findings that may not be as important on patient care. Third is to discuss application of imaging in the treatment of runners. And lastly is to apply the imaging findings in our running scenarios, which will be our focus today. So I'll take the first case here, and this was one of my patients. She was a pole vaulter. So pole vaulters do have to run, so it is applicable to what we have here. And she is a post-collegiate athlete with insertional Achilles tendinopathy. So she was, at the time that I saw her, she was 28 years old, and she had a 2-year history of insertional Achilles tendinopathy. She was actually not able to compete for those 2 years and was thought it was time to retire from the sport. Upon exam, she had pain with palpation on the insertion of Achilles at the calcaneus. She had pain with passive dorsiflexion and active heel raises. Her Visa A score was 57%. Her tendon thickness, which I measured with ultrasound imaging, her left side, which was the involved side, was 8 millimeters thick. And I take that from different spots for different athletes, but for her, since it was insertional, I try to go on a consistent spot on the calcaneus with those measurements. Typically, I'll see 4 to 6 millimeters with those measurements. Her right side and uninvolved side was 6 millimeters. And then I also like to do tendon stiffness measurements, and I have kind of a novel tool. It's called a myotonometer here on the screen. And typically what I see with tendinopathies that involve tendon is usually not as stiff. Usually Achilles tendon or healthy Achilles tendons, I see 800 to 900 Newton meters. So I track that with this case. Here's an image about 4 months in. It's pretty pixelated and it's from my cell phone, so I apologize for the quality here. But you can see on the right side of the screen, there is the Achilles tendon. You can see a dotted line that was measuring the thickness. Labeled as A there. And at this point, my patient's tendon thickness had gone from 8 millimeters down to 0.51 centimeters. So I had tightened up quite significantly at that point. Superficial there's some subcutaneous tissue. Deep to there's the bone. So bone will be hyperechoic or white and will cast a dark shadow below it. Right in the middle of the screen, there's a dark area, and we call that a hypoechoic or darker area. That's a normal finding there, and that would be a fat pad, which is common. Other things that I look for on this, and I'll probably answer some other questions about this in the Q&A, but I look at the quality of the fibrils within the tendon, look to see if they look organized and parallel and so forth. So that was her image. Here's a video of me, or actually it's a picture of this actual patient when I was taking her tendon stiffness measurement. So it's a consistent setup every time. The myotonometer has a little a gauge on the end of it that creates a quick little impulse, and it measures the how quick the tendon rebounds and maps that and can give you a tendon measurement. It's not as probably accurate as putting a tendon under strain and looking at the amount of movement with a certain amount of a load that you'll see with shear wave electro imaging type of techniques. But it's a quick and easy thing that I like to just follow up with my patients with and just track over time. So some of the things with ultrasound imaging and that are particular to this case is it works really well to look at soft tissue. So tendons, muscles, nerves, vasculature, those type of things. With tendons, I like to look to see if there's any signs of disrupted fibrils and tendon structures. It helps me locate where effusion is, if it's within the tendon with neovascularization, or if it's the subcalcaneal or retrocalcaneal bursas. I may modify my treatment a little bit more with what I do for shoe modifications and so forth. And so yeah, I'll use this just to rule out a lot of sinister things, but also use to help really empower my patients and make them believe that they can actually get better is probably the most important thing that I do with it. A couple other things here, just normal tendon under ultrasound imaging should be pretty hyperechoic or white looking, and it should have pretty distinct parallel fiber patterns. What would be maybe not as good of a sign would be thickening of that tendon. That would suggest neovascularization, which is highly painful to our patients. If the fibers are disrupted at all, suggesting some type of tear, sometimes you'll see calcium deposits within the tendon as well. And I'm always, usually it's rare that I'll have these, but a complete disruption of the fiber types. You can usually you'll see that with your exam, but this would help rule it in with ultrasound imaging. So with the tendon, it's a place that's really easy for me to image, especially Achilles tendon, because it's so superficial. Again, ultrasound imaging is the modality of choice a lot of times because it's easy to use, it's quick, it doesn't expose our patients to any like radiation. And with like compared to MRI, for example, with tendons, we don't have slices or cuts. It's pretty continuous what we can do and measure with it, so we can really scan the tendon pretty well. MRI can miss certain things because it is different slices of tissue that you're getting. Also, it's dynamic, so I really liked to be able to move structures around. If I'm looking at something, I'm like, is this the flexor hallucis longus? Is this soleus? What am I looking at? I can move that great toe, and it'll tell me that that's the flexor hallucis longus, for example. And we can do dynamic kind of feedback with what we're doing. So a setup for ultrasound imaging of the Achilles tendon, a patient's prone, transducer. Normally, I'm going longitudinal along the Achilles tendon as demonstrated in this picture here. And here you can see a much better picture than I had before. The parallel fiber types of the Achilles tendon along the top of the right screen there. They label the calcaneus for you there. You can see a little bit of the soleus kind of starting to come in there. There's no swelling of any subcutaneous or calcaneal or retrocalcaneal type of bursas with this image. This is a good looking tendon. So back to my patient, some of the things that we did once I had buy-in, she was really worried that if she loaded her Achilles tendons too much, it would rupture. So we know a mainstay of Achilles tendinopathy treatment is a progressive intentional loading program. So that's what I eventually was able to get her to. I used Karin Silbernagel's kind of articles and so forth to help guide that. And then the Baxter loading index as demonstrated down here, but below. We used the pain monitoring scale. I used a green as being 0 to 3 actually versus the 2 that's in this picture. But regardless, I really reinforced to my patient that we need to load this tendon intentional, and this is how we're going to do it. And we had great guidance from past researchers to guide us there. Outcomes for my patient here, her Visa A improved over, and this is just the first 4 months here, it improved 20 points. Her tendon thickness, as I mentioned before, went from 8 to 5.1 millimeters, which is a significant improvement. It went from abnormal to what I consider normal. her tendon stiffness, which we don't have great guidance on these numbers at all, but anecdotally, I usually see 8 to 900. She went from 733 to 852, so a significant improvement over the course of those 4 months with intentional loading. I noticed that there was a positive correlation as the tendon got stiffer, her visa A improved. There was a negative correlation with tendon stiffness and tendon thickness. So as the tendon tightened up, in my mind, got thinner, the stiffness went up. And this all was correlated with her ability to run and jump. Longer term, that first year, she was right away able to win some international televised meets. She was able to PR that first year back after missing 2 years. She just missed out on representing the United States at the Olympics. Fast forward, she continued to make progress. She recently represented the United States at the Indoor World Championships and is continuing to train at a very, very high level now. So she was able to get that 2-year hiccup behind her and is just killing it now. So great long-term outcomes. So for her, some of the learning points and takeaways from this case is biomechanical properties improved simultaneously with the tendon loading program. So we saw improvements with her symptoms, both verbally and what she was able to tolerate with training, and her visa A improved. It demonstrates that tendon thickness does and can change with the incremental and intentional loading program. And ultrasound imaging for this case really helped with the buy-in to help support our evidence-based tendon loading program. And it is certainly a first-line exam that we can use with tendons, muscles, nerve type of things for sure with our patients in the right hands. And if we go back, I just want to answer, we reached out to some Running SIG members for some potential questions, and Katie from Ascend Physical Therapy had a great question for me. And she wanted to ask how the ultrasound imaging contributed to expectations and any changes in treatment for the Achilles tendinopathy. So for me, if I were to see really disrupted tendon tissue, that would make me maybe a little suspicious of a possibility for a tear. I'd probably be a lot more conservative with how I'd progress their tendon loading program, depending on where they are in the season. Sometimes we gotta encourage them to maybe push a little more aggressive into the pain than we normally would. Let's say a conference is coming up for one of our athletes and it's their 5th year and they have no other opportunities. That may help inform our decision with that. It also helps if I have like a subcutaneous Achilles bursa that's really fat. And I can try to palpate that superficially, but if I see that on imaging, I'm going to do a shoe cutout of some type and try to unload that for my patients so that they don't have nearly as much pain and so forth. If I see some calcium within the tendon, that may inform acetic acid iontophoresis, for example, as well. So some of the different ways that ultrasound imaging may change my treatment plan. So thanks.
Thanks, Matt. And I'll transition into imaging that's appropriate for hamstring strain injuries. So I've got a few cases that I'd like to share. Actually, I'm going to focus on this case 1, and I'll just briefly touch on the other case 2 and share a little bit more about case 3 as well. Case 1's a 20-year-old male football player. He had acute onset during competition, deceleration mechanism, and certainly had some significant pain with ADLs after injury. And in this athlete, he did have initial imaging, which was part of an additional observational study that we were doing. So he had time of injury imaging, as you see on the screen, and he had significant involvement of both biceps femoris and semitendinosus at the time of injury. But I want to mention that this MRI was not actually shared with his rehab team, his sports medicine team. It was, again, just used for research. But some interesting findings will come as we continue to discuss this case. So brief overview of his rehab. Again, this was not influenced by imaging, but pretty standard rehab, starting with core isometrics and gradually progressing increased range isotonics to the point of eccentrics, and ultimately sport-specific and speed-specific drills as he would return to sport. He did return within 20 days or 21 days, so 3 weeks, and he had full clinical hamstring strength at time of return and was able to successfully complete all of our functional tests. So I want to mention, or at least touch on imaging just a bit more in this case. So oftentimes we hear of muscle injury grading scales, usually ranging from grade 0 to grade 3. There's several different types of grading scales. On the screen, you see 3 images of 3 different athletes at our institution, graded by radiologists, with both in red, a modified Petrins, and in green, what we call BAMIC, British Athletic Muscle Injury Classification System. But what's interesting to note is, again, on the screen, you see days to return to sport, RTS, in each of these athletes. On the very left, we see a female track athlete who essentially shows no change in signal in her MRI. Yet despite that, it took her 29 days to successfully return to sport. And again, on the far right of your screen, you see the athlete we're talking about in this case, with much more obvious signs, much more larger hyper intensity on his MRI, and his MRI would either be graded a 2 or 3, depending on which scale you're using, yet he took 21 days, fewer days. So what's interesting to note here is that there is agreement in how radiologists actually score these scales. So the reliability, the repeatability of the scoring is appropriate, but there's substantial variance in how those grades actually correlate with return to sport time. So the prognostic value of MRI for hamstring strains at the time of injury is actually limited. There's a trend towards some positive findings with increased length and the exact tissue that is involved at the time of injury, but some of that evidence is inconsistent. So use caution when or if you do happen to have a time of injury MRI in that image's ability to serve as a prognostic indicator. And in fact, there's been some interesting evidence and research that's been done that shows that clinical assessment may be just as predictive of prognostic or return to sport time as that MRI assessment. So an interesting aspect of this first case that I want to highlight is that he, as part of this observational study, he actually did have repeat imaging about 14 months after his initial injury. So again, his initial injury was sustained within season. He returned to football within 3 weeks, had a successful season as a starter on the football team, and actually went on to have a successful performance and participate at a professional level in the NFL. Despite that, we did find some interesting imaging findings at 14 months after his initial injury. And on the screen, you can see on the left side of the image is his uninvolved limb. And on the right side of the image, you see significant increased signal all throughout his biceps femoris long head. And that's indicating, in this case, denervation edema. And this was due to damage of the tibial nerve, a branch of the tibial nerve, and essentially is causing that denervation, the hyper intense signal all throughout his biceps femoris and a portion of his semitendinosus. And what's interesting in this case is that some take homes from this case is that he, despite that, he did again successfully continue to go on and play. And those imaging findings did not influence his initial rehab or his long-term rehab either. He successfully compensated and was able to perform at a high level despite that injury, despite that denervation edema. And then wrap up from this slide is, despite that residual injury about a year, 14 months after, he was able to continue to perform successfully. And currently, the conventional imaging methods, which we saw on the screen, a T1 and T2 image, may be limited in its ability to predict some long-term outcomes. But there's some advanced imaging, especially advanced quantitative MRI imaging, which you see on the bottom of the screen now, that may be more indicative of what's happening at the muscle microstructure level And some early research we've done in our lab at the University of Wisconsin-Madison, the Badger Athletic Performance Lab, has been to quantify those changes in muscle microstructure, especially after hamstring injury. And the images you see, the colorful images on the screen here, are called diffusion tensor imaging. And there's some potential that that may correlate with clinical outcomes and may be a better predictor of some long-term muscle performance and function after hamstring strain injury. So I'll just briefly touch on two other cases here. This is a recreational runner with chronic pain. And in this case, this might be more of the population I see in the clinic. A recreational runner, endurance runner, and he initially had insidious gradual onset. We focused heavily on eccentrics. We did some gait retraining, worked on pelvic position. We worked on his stride length and ultimately modified his running volume. But in this case, he spent years in PT, so got to know him well, continued conservative management for over 3 years. And then as conservative management really stalled or plateaued is when imaging played a role in this case. And sure enough, we did see a chronic injury of the conjoint tendon or the biceps femoris long head. He tried PRP, gave him a little non-running relief, and ultimately a 10x debridement of the conjoint tendon is what helped him and allowed him to return to running. So again, imaging was appropriate or warranted here now after years of plateaued or failed conservative management, and take home, which I'm sure I don't have to tell any of you, these chronic tendon injuries can certainly be challenging. But again, that MRI imaging was helpful for patient education and managing expectations on the athlete in that case. And then finally, I'll touch on an ultra runner here. And I'll apologize, you actually are not able to see her initial MRI image, but this is a recreational runner, again, an ultra runner that I worked with. She had a mechanism of injury not related to running, actually. She had a forward fall as she was ice skating, earned her a trip to the emergency room, actually. She had significant pain and limitations immediately with ADLs. And this was our classic case. She actually did have an avulsion injury of the conjoint tendon, so complete rupture of the biceps femoris, semitendinosis, and she did have a ligamentous rupture of the semimembranosus as well. So she ended up having surgical repair of her proximal hamstring tendon in that case. And the x-ray you're looking at on the screen is actually the post-op x-ray, and you can see the 3 anchors that were used to perform her proximal hamstring repair. So again, a much slower rehab post-op recovery here, but a typical post-op proximal hamstring repair recovery, focusing on immobilization, normalized gait. We transitioned slowly to really focusing on core. Ultimately, we progressed to multiplanar movements. We progressed to eccentric, really carefully monitored running volume as she returned post-op. But a nice success story here. She did ultimately 2 years later return to completing ultra events and is successfully continuing to compete in ultra events to this day. So one important point I do want to touch on with avulsion injuries, in this case, this was a 52-year-old female. So, and we went ahead and her significant limitations at time of injury warranted MRI. But the differential diagnosis that's important here, especially for the pediatric population, is that you should also consider complete ischial tuberosity avulsion fractures in that case. And in that case, the physeal plate might be where the injury is occurring, and that closes between 16 and 25-year-olds. So any high school, even certainly some collegiate athletes with pain at that ischial tuberosity and an appropriate mechanism of injury may warrant ruling out that ischial tuberosity avulsion as well. So I will, next slide, just the last final takeaways here and a Q&A from the audience as well. Just to wrap up that at the time of injury, certainly that MRI or radiograph could be warranted to rule out a complete avulsion. If it warrants surgical care or not, that's important to have the appropriate injury at that point. But if it's a hamstring injury that you feel is within the muscle belly, maybe less severe, and you can manage that, conservatively, imaging may not be appropriate in that case, as the predictive value of hamstring strain injuries using MRI is not as strong as we would like. So I'll just wrap up these cases maybe with one question from the audience here, and we'll circle back to the first case about denervation edema, and how would that awareness of denervation edema change the treatment course compared to an uncomplicated hamstring strain injury. And thanks to Kevin for this question from the audience. And I would say, just to reiterate again, the rehab team actually didn't have that information, and a significant, he was essentially returned to sport and was not actively participating in rehab when we identified that denervation edema 12 to 14 months after his initial injury. So in that case, it certainly didn't affect the rehab, but I think it speaks to the ability for these elite athletes, especially, to compensate and find ways to allow the additional hamstring muscles, to allow the additional surrounding musculature to make up for that deficit. And without that image, we would have had no idea. He would have had no idea. His rehab team would have had no idea, because he was able to successfully perform and compete after that. But I think it is also important to consider how that might contribute to future injuries, future subsequent hamstring injuries, for example. Maybe the semimembranosus in his case is asking or taking up more of the load, and that could lead to a subsequent hamstring injury, which we certainly know happens in this population, or potentially an ACL injury or another secondary lower extremity injury that may result from this initial weakness or initial limitation that we observe. So certainly something to keep in mind. So thanks all. I'll transition it over here to our next speaker.
Thanks, Krista. That was awesome. Really good insight into the various things that we can see with hamstring injuries. And we'll take a little bit of a shift here, and I'm going to talk about a 13-year-old female soccer player with a differential diagnosis of chronic exertional compartment syndrome, also known as exercise-induced compartment syndrome. And in this case, I basically acted as a consult on this, dealing from afar. So I was really working remotely with the parents of this athlete during the time of when they were receiving care across multiple doctors, multiple healthcare practitioners, including physical therapists, massage therapists, athletic trainers. The other thing to think about is, though this is not necessarily a runner per se, when you're dealing with the youth population, very often they're not, hopefully, not specializing too soon with that kind of stuff. So I would see a lot of individuals who are runners per se because they were participating in a running sport. And really, it was the activity of running that really brought her into the healthcare system. So just something to consider when you work with youth athletes. That's typically the case that you're going to see. So the patient presentation for her, like I said, she was a 13-year-old freshman in high school who complained of posterior left lower leg pain, but also cramping after activity. It started in the left leg, eventually progressed to the right, and even bilateral at times. And she did experience at times where she would feel a loss of feeling in her foot after she was running. And the pain became so intense for her that when she was symptomatic after running, she was unable to walk and needed to be carried off the field. Now, I think her history is pretty important here. She's at eighth grade, going into ninth grade. For summer, she goes to sleepaway camp. So she's in the Northeast, which is pretty common to see in the Northeast. And they go to sleepaway camp. And what they do at sleepaway camp is a lot of socialization. They do a lot of activities, but the amount of training that she was probably doing wasn't really close to what she was going to be facing with when she started to go into high school. She did report that she would do a little bit of jogging and aerobic conditioning when she was at camp, but if you really think about the intensity, it probably really wasn't high. The other thing is that she was a pretty high-level soccer player, so she was a freshman, and she actually made varsity that freshman year. And she started to experience the pain about 1 to 2 weeks into her preseason. So was there an actual spike in workload there from an intensity, but also volume kind of standpoint? And I think it's important to note, if anyone has done any preseason soccer, it's very highly, almost like a hell week, like they say. And one of the things that she needed to do was actually run 2 miles in under about, I think it was 15 or 16 minutes. So once again, probably at a higher intensity and a higher volume than she was used to occurring during the summer. Now, she would also get her pain at about 10 to 15 minutes into onset of running. And it was pretty predictable here. And depending upon the intensity and her current symptomatology, it took her at least 30 minutes for her to return to baseline of her symptoms or go pain-free. But oftentimes it would take hours or even to the next morning to become asymptomatic again. Now, her key exam findings, she had some minor tenderness around the lower leg at rest. Obviously, when she became symptomatic, the tenderness went up. And she also reported a sense of fullness or tightness along her posterior calf when she was really symptomatic. She did have some minor pain with single leg hopping. She had some dorsiflexion limitations. And obviously, with any 13-year-old female who's probably undergoing her adolescence at this point, you want to screen for her energy availability. So I did ask the father and the mother some questions regarding and any screening for REDS, and she came up with very low risk on REDS. Her menstrual cycle was pretty stable. Her onset of menses was pretty typical. She's never had a stress fracture before in the past. She's never been diagnosed with low bone mineral density. And her eating patterns tend to be pretty, she pretty had a good relationship with food. So it didn't seem something that was be on my radar, but that's something that you always want to screen for in this population. So going through my mind when I was talking to the parents was, what were my differentials? So obviously you want to rule out some kind of tibial bone stress injury with these folks. Of course, chronic exertional compartment syndrome due to the fullness and the activity-related pain that was very predictable was in my back of my mind. But you always want to kind of make sure that you're ruling out any the presence of any tibial bone stress injury and understanding that that goes along this continuum. So when we usually thought that medial tibial stress syndrome was something a little bit different, we're really learning that's probably just the earlier onset of progressing towards more of a stress fracture. So these folks with medial tibial stress typically have diffuse pain along their distal medial tibia, typically greater than 5 centimeters in length. The pain worsens with activity, especially with running, and could persist about 30 minutes to even hours after activity. And these are typically diagnosed with X-ray, though they may come back normal. But MRI is the most sensitive kind of technique that will reveal some periosteal bone marrow edema or bone marrow edema and some soft tissue inflammation. As it progresses along that continuum, it could progress to some kind of stress reaction and then subsequent tibial stress fracture, where these folks typically report more focal pain. So these are a little bit more tenderness to palpation localized. They can typically take a finger and point to that area. Once again, it is activity related. So it could start with just activity, and then as it progresses, it can become a little bit more symptomatic with rest. And the sudden spike in workload or increase in training volume or intensity is usually a really telltale sign of this. Now, once again, X-ray is what is suggested for these folks based upon the ACR criteria. And they can pick, if it's early enough, they'll typically come back normal. However, if you do repeat ones about a few weeks later, you may see some bony healing as long as they've started to rest and recover from that. However, MRI is typically the best modality here. It's considered the gold standard to find that bone marrow edema, and if there is the presence of some kind of fracture line, that really has a high sensitivity and specificity. And it's really kind of replaced the old diagnostic of bone scintigraphy or a bone scan, which does have some high sensitivity, but also has some high radiation. So looking in, especially this adolescent population, we really don't want to expose them to any unneeded or excess amount of radiation when you have a tool that may be a little bit more or specific and sensitive diagnosing these things. Now, Matt did a great job of reporting the role of ultrasound in his patient with tendinopathy, but there is some growing evidence of the use of diagnostic ultrasound in the diagnosis of bone stress injuries. The problem with diagnostic ultrasound is that it's very user dependent. It's quick, it's affordable. However, the expertise of the operator is something that could be a quite limitation to it. Now, chronic exertional compartment syndrome is pretty much a diagnosis by exclusion. There's really not a lot of ways that we can diagnose this. And unfortunately, there is a lot of overlap between the symptoms that we see with exercise-induced compartment syndrome and some bone stress injuries. There's obviously exercise-related pain that occurs, and it's often relieved with rest. Once again, very similar to what we're going to see with bone stress injuries. But the main symptom that you're going to find with these folks is that they're going to report a tightness or a cramping or possible paresthesia or numbness, tingling, neurovascular type of complaints that may or may not be present with tibial stress fractures. So like I said, these are a diagnosis by exclusion. You're doing MRIs and X-rays and other advanced things to rule out other things. But the gold standard for this at this point to diagnosis is intracompartmental pressure measures, and we'll go through that process. Unfortunately, the specificity and sensitivity on it is not great, and there's a lot of limitations to its use. And then there are other kind of advanced diagnostics that are currently being studied. Near infrared spectrometry that really evaluates the amount of oxygen saturation and changes in the muscle tissue with rest and versus when they go under activity. And then also some shear wave elastography, which you tend to see some increase in shear wave modulus associated with the increased pressure after exercise compared to normal controls or healthy controls. So at this point, the patient was symptomatic. They were seen by their school athletic trainer, and their athletic trainer did refer them to a primary care sports medicine physician, and with their suspicion of chronic exertional compartment syndrome. So just the etiology of chronic exertional compartment syndrome, it's really unclear of the full etiology, but what we think happens at this point is that with certain amount of exercise, there's going to be an increase in the intracompartmental and intramuscular pressure of the lower leg. And as a result, there's ischemia or decreased blood perfusion to the muscle, or the neurovascular structures. And this could be due to a few different reasons. So it's with exercise, we get muscle hypertrophy acutely, or it could be due to just the non-compliant fascia or tissue around the muscle then constrict the available blood supply and neurovascular perfusion to the lower leg. Or it could be due to some kind of decreased venous return as a result of the increased blood flow that occurs with exercise. So we really don't know the true etiology of this at this point. These are multiple things that have been studied in the literature, and there's probably a potential for multiple of these things happening at this point. So the images that this patient actually received, like the ACR criteria recommends, plain radiographs were the first line. It's a really nice way to it's quick, inexpensive, and relatively low radiation comparative to other more extensive means. And they came back unremarkable at this point. So due to the high suspicion of her history and alternative diagnoses, she was then recommended for an MRI, and she had an MRI of both tibia and fibulas without contrast. And what they found was a very low-grade osseous stress response and or shin splints along the anterior medial mid to distal tibia of both limbs. And you can see the MRI to the right over here. I believe this is a stir image, and a stir image is a really good image to look for bone stress injuries on along the continuum, because like the T2 images, you're going to see the fluid and water come up really bright. But what's different is that it will also suppress a little bit of the fat content to allow a little bit more contrast in the bone. So you can see here to the image to the right, the top one's going to be her left image, her left tibia, where you could see that increased signal along the posterior medial tibia, and it spans almost about the distal 2/3. And then you could see something very similar on the right, just not as present. The good thing is that there was no evidence of acute tibial or fibular fracture that they saw. So once again, due to the high suspicion of exercise-induced or chronic exertional compartment syndrome, I talked to the family at length about this procedure and the limitations, and they were on board. This is an invasive procedure that, especially for a 13-year-old, can be quite painful. But they decided to go ahead with the intercompartment pressure testing. And what it is basically you start with a baseline test at rest where they break the skin and take a catheter and goes into the actual compartment of the lower leg. You do one of each lower leg. And then you get a baseline. And then you're going to then hop them on a treadmill or do some kind of activity that's going to aggravate their symptoms. And once they become symptomatic, you're going to repeat those pressure tests at about a minute after exercise or onset of symptoms, and again at 5 minutes or 5 minutes after stopping activity. And there's a lot, and we went back and forth with whether they should do this or not because of the invasive and potentially painful for a 13-year-old at this point, because the evidence behind it's really not strong behind the accuracy and reliability of this. And that's likely due to the variation in diagnostic criteria that exists determining the cutoff values, but also a lack of standardized testing protocols. It's kind of little, I don't want to say the wild, wild west, but there's really little agreement as far as the best way to do these things. So the guidelines that have been established on this are variable. So Pedowitz probably has the most commonly adapted ones, where they find it to be positive if one or more of these diagnostic criteria are satisfied. So if they have a pre-exercise pressure testing of greater than 15 millimeters of mercury, and then after 1 minute it rises to above 30, and after 5 minutes it then decreases a little bit, but still above 20 millimeters of mercury. Now, there have been other guidelines that have been established where 1 minute after exercise, if pressure is above 27.5, along with that combined suggestive history, which does a nice really job of linking symptoms with the results of a study, which I think we should be doing all the time. And then Roscoe has then since been a little bit more progressive in this, where they're doing a little bit more of the monitoring during exercise, which may be a little bit more difficult. So a lot, like you could see, there's a lot of different criteria that makes the interpretation a little bit more difficult. So looking at her results, on her right side, separating it by anterior, lateral, deep posterior, and superficial posterior compartments. On her right side, her pre-levels were all above the initial criteria that would be suggestive of exercise-induced compartment syndrome, but really that deep posterior compartment stayed a little bit more elevated at rest, or I should say after exercise. On the left side, same kind of thing, except this time her anterior, lateral, and deep posterior were both implicated, both pre and post, with the superficial posterior compartment not really being affected. So once again, we went back and forth with the parents, and I was working with one of the doctors on this, who I referred to in their area, who I used to work with, after all, we really went back and forth deciding what is going to be the course of treatment for this. Are we going to stay conservative, or are we going to go more surgical management with this? Now, the problem with, and we kind of weighed the positives and negatives with both of these. Now, conservatively, it has its benefits. It's obviously non-invasive. The only problem with this is that the outcomes for conservative management is not very high. Only about like half will be satisfied with their result, because only 50% will be able to return to their prior level of activity. However, surgically, it's not all what glimmers is gold there either. And obviously the gold standard here is going to be an open or endoscopic fasciotomy. And the outcomes for this is better than conservative management, with 2/3 of young athletes having successful surgical outcomes. So 2/3 is great, but that's still only 66%. But unfortunately, there's lower outcomes in female. And if you recall, this patient is a female 13-year-old. And furthermore, when multiple compartments are involved, the outcomes tend to decrease, especially when when the compartment involved is outside the anterior compartment. So that deep posterior compartment really doesn't perform well conservatively or surgically at this point. Not to mention, whenever you're doing any kind of surgery, there's potential risks of complications, whether those complications be infection, whether they be return of symptoms, whether they be nerve damage. And there's almost a 2 in 10 likelihood that someone undergoing some kind of compartment release fasciotomy is going to have some kind of post-surgical complication. And the other thing to consider is, once again, there's a higher likelihood than, say, other procedures of recurrence of symptoms even after having this procedure, and even likelihood of having a repeat surgical procedure. So once again, we kind of went back and forth and discussed a little bit of the conservative, the kind of ways, the positives and negatives to both of those. So this really goes into the shared decision-making model that we utilized with this patient, between the parents, the athlete, and the healthcare professionals together, and this team-based approach, really presenting the evidence, presenting what we have, and the risks and benefits associated with each of them. So this family opted to go for more conservative management, mainly because, especially due to the imaging findings, her history, the onset of symptoms, we weren't really 100% positive that there wasn't anything outside, that it wasn't compartment syndrome with or without any kind of bone stress injury on top of that. So we really wanted to say, well, let's maybe not do the fasciality. Let's kind of rule out if there is a potential bone stress injury, managing that may be conservative first. Obviously, the risk of complications after surgery was concerning for the patient, also for the parents, not having them have to do a repeat surgery, along with the prognosis of this surgery is not very high. So if they needed to try the conservative route first, probably one of the main things that also affected them was their timing. If she had a bone stress injury and we're going to manage a conservative, she probably would have missed the season anyways. So delaying the surgery probably wouldn't have allowed her to miss a lot more time. So they actually had the time in the bank for them to try that conservative route before going into that surgical procedure. With any 13-year-old, if it's a 13-year-old female, I don't want to say this is vain by any means. This is real life. She was very concerned with the scars associated with the potential more than one compartment and having multiple scars down both of her legs at this point. So that definitely weighed into the discussion a little bit. Probably one of the reasons why she opted for a conservative care is she did have such a great support system. Her parents were totally on board and supportive and willing to do anything to really help this from a financial but also activity modification standpoint, and they had the resources to do so. So that really weighed into our decision. So conservative care for her, once again, just to reiterate, I didn't perform the care. I was really helping to guide this from afar with the family, touching base with them multiple times per week. And I think what provided the most was the education. And I think that that's probably the most important thing to do with these folks, having them understand the etiology or what they're kind of facing with, managing their expectations, and also going through the process of what may be beneficial or may not be beneficial. Now, we did throw the kitchen sink at this one because at this point we were like, you know what, let's exhaust all of the things that could potentially help this patient, even though the evidence behind them may not be that strong. It is something that we wanted to exhaust for this patient and this family. We did a lot of activity modification, especially trying to rule in and rule out or manage a potential bone stress injury here, or a bone stress, that medial tibial stress syndrome potentially. She did a lot of stretching on her own and was very diligent with that. They actually paid out of pocket to do some soft tissue mobilization techniques, whether that be some I think they did ART with a chiropractor or a specialized massage therapist in their area. We did, once again, due to her foot posture, and try to use some over-the-counter orthoses to help manage some of those symptoms, and was guided into a general lower extremity strength and conditioning program whilst being very mindful of her symptoms. And then we used modalities and NSAIDs, PRN, teaching her that NSAIDs shouldn't be used just to mask the symptoms to allow her to do what she wants to do, but really kind of help her with her day-to-day life while paying mind to her symptoms. I use a lot of the same things that Matt talked about earlier with the pain monitoring model. I really look to that a lot, except with these bone stress injuries, I don't allow any pain with any of that activity. So that's one of the things that's the big caveats with this. So we were pretty on board with this, and the parents were very monitoring, and the athlete was very helpful with this as well. So the outcomes for her after 4 months, she had a slow progressive. She was able to slowly and very progressively return to her sport, into running. Looking now, I think she's about 9 months down the line. She's currently unrestricted in activity. She's starting to play back some soccer. She did a little bit in the winter in indoor soccer. Unfortunately, talking to her parents, she's not playing at the previous level, meaning that she used to be really high level as far as her talent. She's kind of regressed back to her. She's not the superstar as she once was. She continues to use ice and foam rolling before activity, whether that's helpful or not to the athlete. If she feels it is, so I told her to keep going with it. It's not something of my first line of treatment with these folks, but the athlete actually found that it was helpful for her. So I said, hey, go after it. She only has very low level intermittent symptoms at this point. She's not really affected in her participation. She's able to participate. She may get a little bit of soreness. It doesn't really persist or limit her activity. So she's kind of going at it. And most importantly, she's happy to be back with her teammates, which I think is probably why we do what we do. So just some learning points from this. I think the complexities of compartment syndrome and the diagnosis, it's a very muddy environment. So to sift through that, it's a lot of education and clinical decision making. I think the reason why this athlete had such a good outcome is that we were able to manage the expectations of her and her parents. They were very on board with everything, and the communication between the team members was really on point. And this may change my decisions for another patient, right? So we really made individualized shared decision making for this patient in front of us, which may not have been the same decision if it was for a collegiate athlete or someone who's a senior in college. So I think having that individualized approach is going to be important. And then I put in here research versus real life. Like, I understand that a lot of these interventions are not do not have really high evidence, but at this point, there's no real great option for conservative care for this condition. So we really threw the kitchen sink at her, and I really didn't care which one worked at the given time. Because the parents were on board and had the resources, luckily, to do those things, and they were willing to take those, even though I told them the outcomes could not be guaranteed, but they were willing to try. So this is one of those where research versus real life may not, how to translate that research to real life may be a little bit of a different story. So that's all I have. So there was a question from one of the listeners, and their question was Kevin. He asked, is a two-step MRI, so an MRI that's taken pre and post exercise, a feasible and accurate alternative, and feasible from the standpoint of procedurally, but also financially, to needle manometry for diagnosis of compartment syndrome, exercise-induced compartment syndrome. And, that's one of the things that's up and coming. And I have never seen the two-part MRI at this point. I think it's obviously very expensive, time-consuming. You also need to have a treadmill or some kind of way to induce the exercise right next to the MRI machine in order to get that pre and post. So I think it's one of those things that in a research standpoint, or the resources for a hospital-based system or more elite level athletes may be more practical. I think for the general population, at this point, probably is not something that we're seeing as often unless they're going to some kind of specialized center that deals with this pretty often. But that's still being worked out in literature. So that's all I have for here, and I will turn it over to Jacques for.
Awesome. Thank you, Eric. So I'm going to take lead on our last case for the day, highlighting lateral foot pain in a rec runner. This is actually a case that was published in JOSPT in 2017, and I'm just going to highlight their evaluation and exam findings, and then their differential diagnosis, and wrap up with their outcomes and treatment. So the history and background on this case: this was a 35-year-old male recreational runner who experienced gradual left lateral foot pain over a 9-month period, which was exacerbated by increased running frequency and intensity over that time. There was no known mechanism of injury or cause, no lateral ankle sprain or anything of that sort. The patient self-referred to physical therapy while awaiting an orthopedic consultation. However, his primary care physician at that time also ordered radiographs. So when he came and self-evaluated with physical therapy, the exam findings that were found were that the patient had pain rated at 7 out of 10 with weight-bearing activities. They had localized tenderness at the lateral border of the left foot and fibula, and their pain was also reproduced with active plantar flexion and inversion. Eversion strength was fairly decent, 4- out of 5, but not great, and was provoked pain at the same time. They also had pain with palpation at the base of the fifth metatarsal and cuboid with restricted cuboid mobility when doing joint play. And then with a gait analysis, there was found to be decreased step length and also a painful push off with this patient. So just before diving back into the case, I know that the Ottawa ankle rules are typically used to determine whether or not we should introduce radiographs into our care and decision-making with more of these acute injuries. And although this person, had a 9-month history of their pain and it's more of a chronic injury, I still think this can be a useful tool as, the indications or benefits are to save time, save money, and the costs associated with radiographs and to avoid radiation, but can still be an indication for maybe when we should not use imaging in these types of individuals. So as for this patient with foot-related injuries, the Ottawa ankle rules for foot imaging would be pain in the midfoot zone and any of the following, which would be bone tenderness at the base of the fifth metatarsal, which the patient had, bone tenderness at the navicular bone, and unable to bear weight immediately for 4 steps. So this patient did have midfoot zone pain, as well as pain at the base of the fifth met. So even though it's a chronic injury, I would say it's a good indication to probably get imaging for this individual. Just highlighting some radiograph basics. Obviously, our standard imaging modality and produces 2D images based on varying absorptions of ionizing radiation to differentiate between tissue types, assess bone integrity, as well as other structures within the foot. So some of the pros to this are that it is fast, accessible, and cost-effective, especially compared to some of our counterparts like MRI. As far as detecting fractures, dislocations, and bony lesions go, it is very effective. And it can be useful at identifying accessory ossicles in the foot. As far as cons go, it can be limited in its sensitivity for subtle or stress fractures, especially in those acute early phases after a stress fracture develops. It has inadequate visualization of soft tissue structures. So if you had a ligamentous issue or a cartilaginous issue, radiographs may not give us what we need there. And then if we don't, find what we're hopefully looking for, or if everything is negative with a radiograph, then we may require further imaging, which is just an added cost and time demand for the patient. Just highlighting some of the common imaging views. I'm not going to like dive deep into these, but just to highlight them, I would say our most common is an anterior posterior view of the ankle. Looked to assess medial and lateral malleolar fractures, tibial flange injuries, and look at overall joint space narrowing, seeing if there's any indications of arthritis in the area. As for this case, we have a lateral view of the patient, which is taken with the foot in a slightly dorsiflexed position and with a lateral projection from the X-ray beam. This can be good for malleolar fractures as well and other subtle injuries to the talar dome and subtalar joint. And then lastly, we have an oblique view, typically taken with a 45-degree projection, and can help us identify some of those additional obstacles that may be, preventing or increasing pain in those regions that they're presenting. So these are the images from our actual case for this individual, this patient, and in both the lateral weight-bearing view and the oblique view, we see no acute fracture, so no indications of fracture or stress fracture, especially considering that this patient had been having their pain for about 9 months. Joint space looks good between all the carpal bones, as well as there were findings of os trigonum with a ossicle growth at the posterior region of the talus, os navicular, and then fragmented os peroneum, which is where that arrow indicates right off of the cuboid bone. So running through the differential diagnosis that the researchers in this case study used, first, wanting to rule out stress fracture, they were able to do so due to the chronicity of the pain this patient was presenting with, as well as there being no evidence of fracture being found on their plain film. They then wanted to look at os peroneum diastasis, and this was also ruled out due to no acute changes on the plain film. Also, os peroneum diastasis can also be linked with a peroneus longus tendon or rupture, and they didn't have any issues really or pain sensitivity with specific muscle testing of that region. When we look at symptomatic fragmented os peroneum, as well as fibrillaris tendinopathy, these are both diagnoses of inclusions. So these were ruled out as we were able to come to a different diagnosis, which was cuboid syndrome, which they were able to confirm by meeting the proposed criteria that were published in 2005 by Jennings and Davies. So just looking at this cluster here, the patient highlights a lot of these with their case, which was an indication to diagnose them with cuboid syndrome. They have pain on palpation at that lateral aspect of the foot. They had restricted mobility through their carpal bones, especially in that mid-tarsal region by the cuboid. Pain with their dorsiflexion and plantar flexion, and then antalgic gait, as well as the pain location, just generally speaking, was also an indication that cuboid syndrome may be a possible diagnosis. So interventions for this were actually pretty cool to see. This patient received a cuboid manipulation at their first visit and experienced almost 100% of resolution in their symptoms immediately. They were able to normalize their gait, tolerate weight bearing without that 7 out of 10 pain, and return to running, just as off of one cuboid manipulation. The patient continued to, do self-mobilization techniques at the carpal joints, trying to increase mobility at the cuboid, and it worked on their peroneal strengthening as well. And then did not return to running at, they had already progressed with increased volume and intensity prior to the injury, and were continuing to try to throughout the injury. So they followed a structured return to run progression, starting with a little bit lower volume. As far as their outcomes, they did see physical therapy several more times over the course of several months, just to, check in on things, make sure things were going well. But they were able to achieve full mobility and strength and return to full activity over that time. Their foot ankle ability measure score improved from 39 to 84 to a complete 84 over that 69 days. And they were able to maintain this following therapy, at least through the 15 weeks that they were followed, with no need for surgical interventions. So my take-home points for this case are that, imaging helped to rule out fractures in the os peroneum pathology, which allowed the PT to confidently rely on their clinical exam. We didn't have an indication for surgery, didn't have an indication for stress fracture. And so that really opened up the door to think that this was cuboid syndrome and attempt a cuboid whip to see if that would resolve their systems. The restricted Q mode mobility was identified through this hands-on exam, emphasizing the importance of correlating the imaging with the clinical findings to guide targeted interventions. So they may have had these incidental findings of os navicular, os trigonum. However, just based on pain location, things of that nature, and their physical exam, we were able to note that those weren't probably the primary cause of their pain and symptoms. And then just a collaborative approach between this imaging and physical therapy exam enables us to focus on the conservative care, as we would always, hope to be able to opt for that as opposed to relying on those surgical interventions with runners who, don't want to take time away from their running, obviously. So that's what I have. A question that was asked regarding this case was, what injury history and presenting signs and symptoms may prompt a physical therapist to seek radiographs to assess for either potential fracture or migration or movement of the os peroneum? I think kind of circling back to the Ottawa ankle and foot rules, positive findings on that, pain in the midfoot region and an inability to weight bear are really like local to that region where the cuboid may have extra accessory bone growth. I also think that, if you're suspicious of a peroneal longus tear or rupture, granted, this was not an acute injury, but looking at those things as they can be an indication for that diagnosis could also maybe lead you towards that diagnosis instead. So when we talk about that, looking at pain with resisted plantar flexion or with the first ray, swelling, bruising, any palpable defects along that peroneal tendon, and then just pain with active and passive movements as well. And that's what I have.
Great. Thanks, Jacques. So I love talking shop, and getting some imaging that's novel too and specific to runners is always fun. So thank you, Christa, Eric, Jacques, for coming on today. I just want to remind everyone to check out the Sports PT AASPT website. It's sportspt.org, and on there is our calendar of educational content. So check that out. There's plenty of content that's being put out there for everybody. And something to note as well is that the podcasts are all available on YouTube at the AASPT. So check that out. Podcasts are going to be continue to be available there for everyone. So I appreciate everyone giving us their time to hang out today. Thanks.